Good to go. I'm Jerry Hesch. I work in Aurora, Colorado. I have a nice little home office. You walk in the house, it's right there on the right side. In my free time, I can easily access my books, do research and writing and course development, etc. And I'm happiest if I see a small handful of clients, but I spend a lot of time with them. This client, I'm going to spend 2 hours with her on 3 consecutive days. They come from Canada, and I'm in Aurora, Colorado, so I need to really optimize the care that I give them and optimize what I teach them about self-management. And they've already spent enough money. They've seen 8 chiropractors, at least 8, and multiple visits with each one of those practitioners, at least 4 to 6 physical therapists, anywhere from 4 to 8 visits per therapist, acupuncture, different specialists, podiatry, four different orthotics. None of them helped. And their frustration is that no one's able to give them a clear answer of, what is it? Why do I hurt? Now, we do know that there is mild to moderate degenerative changes in her cervical, the cervical spine at the C4, 5, and C5, 6 level. And she's getting some numbness in her fingers, and she also gets some in her feet as well. And at the moment, I'm blanking out on the lumbar pathology. Can you fill me in? There's a little bit of degenerative changes at the lumbar, but nothing overt, nothing such as severe stenosis, no disc fragments sitting on a nerve root. So we have someone with pain in multiple areas of her body. Okay? And no one's been able to give her a clear answer. What I do with my clients is I evaluate gross movement, but I especially isolate small movement. And when you treat small movements in the body, you get a big window into the nervous system, and you get to affect the nervous system in a very profound way. To give you an example of a small movement, we do need the toe to be able to lift up when we're walking to push off. Otherwise, we develop some compensation. So what I want to do is I want to test, does her toe extend? It extends beautifully. She has plenty of range of motion. You might say she's a bit hypermobile. That's almost 90 degrees. That's probably 75 degrees. So I take a structure to the end of its motion until it stops moving, okay? And then I add a little thrust, and her toe, I brought it up to a stop point, then I thrusted it and add a little further movement, and it bounced back with integrity. So that's her norm, so I would expect that on the other side. By doing these micro motion spring tests throughout her body, I feel strongly that she is going to be one of my unique cases. Probably one of the top 5. I need to build the case and then support that. But the proof is in the pudding. Okay? I'm going to show you where motion is lacking in her body, and we're going to treat it. We're going to start treatment today, continue tomorrow, and then we will refilm how her body changes. Okay? Well, having screened her whole body, I would expect her to have normal dorsiflexion, in which the foot moves at the ankle. So if I push her foot up, she should have about 15 to 20 degrees. She doesn't. She's at 0. She's at a 90-degree angle. There's no dorsiflexion. If I try and spring it, there's no give. The same is true for the cuboid on both sides of her, on both feet. And then the other thing is the joint below the ankle does not have eversion nor abduction. So when I twist the calcaneus, her foot should point outward. It doesn't. Okay? And I should be able to lift the heel outward, swing it outward, out and up. Nothing. I can swing it in the other direction, and I can adduct the foot, but I can't go the other direction. That's true on both sides. Okay? Her hip motion is excellent. Knee motion is great. Hips move in all directions except her hips do not glide forward. So I'm going to take the hand and come underneath, and I'm lifting forward towards the ceiling. And it's already at end range. I can't get any of that movement. But I can roll it in, I can roll it out, I can make big circles. When she's on her stomach, I can extend that hip beautifully, but I cannot get that micro motion named glide. Okay, moving up the body, she has no movement through the pelvis. I cannot glide her pelvis left or right. I cannot induce rotation of the pelvis on either side. Okay, staying with the pelvis, let's have you lie on your stomach. So we are preserving her privacy. So she wears sunglasses when she's on her back, and she has a mask. Okay, so I like to spring on the back of the trochanter, and there's a rather flat portion there, and it gives me the same information of a lack of a forward spring, same information I can glide doing the spring test here. Okay, her pelvis has no upward motion, no downward give. Sacrum is very prominent. This is the bottom of her sacrum. This is her PSIS. Here's her right PSIS, very distinct. Here's the bottom of her sacrum. Now here is S2 of the sacrum. Look at how much sacrum is posterior in relationship to the ilia, okay? This is a pattern I see when people fall onto their sit bones. And it's treatable for most people. Now, because I can't get any motion through the pelvis, one conclusion would be it's fused. Okay? However, there's something that causes me to believe that it's not fused. Sacrotuberous ligament is here, so I'm about mid-belly, and I get right on it. It's prominent. Why is it prominent? It feels like bone. There is no bone here. Keep the camera angle right there, and I will show you on a pelvic model. And I apologize for the length of this thing, but this is a very complex case. And I think at the very end of it, it's going to be absolutely fascinating to see how her body embraces the work and brings her posture, her mobility back to normal, and how that interacts with her pain, her experience of pain. Every night her husband has to massage from her head to her toes. How long does that take you?
2 hours. 2 hours.
2 hours.
Using machine gun. I mean,
You use
massage
a
gun.
machine,
The massage gun.
a massage gun for 2 hours a day.
Yes.
No, 2 hours a night. Every
Good
night.
night. Yeah.
Incredible. Incredible. Coming back to the pelvis. So this is her right sacrotuberous ligament. Okay? And look, I can go inside the pelvis, and if I cut it, I would be able to just lift, you know. Okay? So there's no bone here. And yet, it feels like bone. Because it feels like bone, I think there's a positional difference in the pelvis. And that if we restore normal mobility and positioning, I think the ligament and the tension in those ligaments will change. Now, coming up the spine at L5, I can load it and spring it. And I would expect you to be tender there, and even at 4. And I get motion at 3 and 2, 12, 1. Now I might be off by 1 vertebrae, but I don't care. It is not about necessarily saying I'm on 12 and I'm on 11 or 12 or L1. It's about What is the quality of movement? And in this example, I want to know if it's stuck, if it doesn't move. That's big information. And guess what? As soon as I get to the thoracic spine, there's no movement. I cannot induce posterior to anterior spring all the way up her thoracic spine. Okay, now some people would think, aha, maybe it's one of those inflammatory types of arthritis like ankylosing spondylitis. And I'm just going to put that thought to the side and say we're not ready to think that way yet. If I can change this movement and change the movement in the pelvis, then that will be proven false. So let's just place that thought to the side for now. She does have good mobility through the ribs, and that's very encouraging to me. Except down here, rib number 12 is deep, and it doesn't spring inward, whereas on the left side, I can load it, pushing it medially, I can spring it medially, and it bounces. Okay, and the first rib on the right does not have spring mobility. Okay, so we're going to now have you lie on your back. So let's just move the camera a little bit. She can roll over and put her sunglasses on.